MedSurg students, in this video presentation, I'm going to be reviewing diabetes. Before I go into the different types of diabetes, I want to go over health promotion and disease prevention. For diabetes type 1, we can't prevent it. It's an autoimmune disorder, which I'll be going over later. However, it's really important that people with type 1 and type 2 diabetes have tight glycemic control. And what I mean by that is they take very good care of themselves so that their glucose level is in a normal range or an acceptable range for somebody with diabetes. So oftentimes they'll have to engage in lifestyle changes. For diabetes type 2, these lifestyle changes are the cornerstone of diabetic treatment. They need to lose weight, exercise, and diet, basically. And look in your textbook on the chapter of diabetes and ATI, and it's got a long list of interventions for health promotion and disease prevention. So make sure you understand them. All patients or all clients that have a BMI greater than 25 and above need to be screened. And this is for diabetes type 2, because we know that people with BMIs 25 and above, that's one of the risk factors for having diabetes type 2. I mentioned previously that tight glycemic control is essential to prevent the occurrence of the long-term complications of diabetes. You can remember these long-term complications with the mnemonic KNIVES, okay? K stands for nephropathy, and that means kidney damage. So people that end up with chronic kidney disease, the two most prevalent diseases they have is diabetes and hypertension. It really puts a strain on the kidneys, and they end up with chronic kidney disease. N is for neuromuscular conditions, neuropathy, which means they can't really feel things, right? Or they have pins and needles, so that's why they have to do things like check their water temperature before getting in the bathtub, because they can't feel the heat, okay? I is for infective. So patients that don't have or don't maintain tight glycemic control are going to be very prone to getting infections such as UTIs, yeast infections, tuberculosis. So we want to keep tight glycemic control to prevent recurring affections, which are common in people with diabetes. Vascular, we want to prevent a cerebral vascular accident, which is also known as stroke, which is also the new term is brain attack. We want to prevent heart disease, and we want to prevent peripheral arterial disease. Okay, so in other words, we want to prevent the diseases of the vascular system that is going to lead to low perfusion in certain areas. People with diabetes can have silent MIs. An MI is a myocardial infarction, and what I mean by silent is they don't have the pain, the chest pain, because of neuropathy. And so they could have a heart attack and not even know it. When I worked in a pre-admission clinic, patients would come in to get their EKGs, and I'd see a Q wave, which is indicative of an MI. And you don't need to know that. I'm just telling you what would happen. And I'd say, when was your myocardial infarction? And they said they never had one. So that's just showing you that people can have silent MIs. E is for eyes, so they're going to be more prone to cataracts and retinopathy, which you learned in MedSurg 1. In the skin, they could get a lipohypertrophy, which means, or lipoatrophy, which means the fat can diminish in certain areas. And so to prevent that, they need to rotate insulin injection sites. So now we're going to review the different types of diabetes. So for diabetes type 1, which was previously known as juvenile diabetes because it happens more in young people, and also it was called insulin-dependent diabetes. However, we have found in recent years that patients with type 2 diabetes also need insulin Therefore, now this name is diabetes type 1. Okay? It is characterized by being insulin dependent. You can't prevent it. It's always going to require exogenous insulin because their pancreas cannot manufacture insulin. They are going to be prone to ketosis. Ketosis occurs when our bodies are starving, and it's from the breakdown of fatty acids in the body. And so what's happening is because there's no insulin to help sugar get inside the cell to be used as energy, the body now has to break down fat for energy. So that's one of the signs and symptoms of diabetes type 1. Diabetes type 2, I had mentioned previously, we used to call this non-insulin dependent diabetes. However, in recent years, people with diabetes type 2 need insulin to control their blood sugar. And it's caused by insulin resistance. Like the cells in the body are resistant to insulin. It usually occurs in people over 30 who are obese, who have metabolic syndrome, and I'll talk about metabolic syndrome pretty soon. Um, Also, people that will be at risk for diabetes type 2 include people that had diabetes when they were pregnant. Also, people with a family history of diabetes. They're going to be more prone to hyperglycemic, hyperosmolar state, which we call HHS. Um, and it's usually also caused by genetic and lifestyle factors. So the cornerstone of diabetes mellitus type 2 is going to be diet and exercise. Metabolic syndrome is a risk factor for type 2 diabetes, and the characteristics include a fasting blood sugar greater than 100, triglycerides greater than 150, HDL, which is the happy cholesterol that we want to be higher, not lower, is less than 40 for males and less than 50 for females. And you can drive that up with exercise. Also, having a blood pressure greater than 130 over 85 is a risk factor. And people that carry abdominal fat, so fat in their abdominal area, is called central obesity. So they will also be at risk for type 2 diabetes. Here are the signs and symptoms of diabetes. The 3 P's, so you're looking for polydipsia, meaning they're very thirsty, polyphagia, meaning they're very hungry, and polyuria, meaning they're going to have an increased urine output. So if there's high sugar in your blood, that means your blood is hyperosmolar, right? So that's going to bring more fluid into the vascular system, and it means that you're going to have increased fluid in your vascular system, so you're going to be putting out more urine. Recurrent infections, I talked about that earlier, so that you need to encourage tight glycemic control. Kussmaul respirations, this typically happens in type 1 diabetes when they get sick and their blood sugars get really high and they become acidotic. So it's a reaction to metabolic acidosis, and Kussmaul respirations, I don't know if you've had this before, are fast respirations. Okay, they're trying to blow off the PaCO2. And then, of course, headache and nausea and vomiting are also signs and symptoms of diabetes. The criteria to be diagnosed with diabetes includes having 2 of these findings on 2 different days. So 2 of the screening tests come back positive on 2 different days. So the first one is a hemoglobin A1C test greater than 6.5%. Now I need to explain what this test is. This test is a test that is used to determine if the patient had tight glycemic control over the last couple of months. So it is measuring the glucose on the hemoglobin in the red blood cell, right? So red blood cell lasts 120 days, so it makes sense that this is going to give the provider some insight into how well the patient maintained tight glycemic control over the last 3 months. Okay, 3 to 4 months, 120 days. Okay, so an A1C, also called a glycosited hemoglobin, greater than 6.5%. A fasting blood sugar greater than 126. Casual blood sugar greater than 200. Okay, so let me tell you what a casual blood sugar is. A casual blood sugar is, let's say, you go in for pre-op testing and they're going to draw your blood sugar. They're drawing your blood sugar without regards to you being fasted, waking up early in the morning. They're just doing a casual. They're taking a blood sugar at any time of the day. So if that is greater than 200, then you may have diabetes, okay? A 2-hour oral glucose tolerance test greater than 200. And if you've been pregnant before, you probably remember this test where you had to go and drink a solution. You had to be NPO before the test, and then they measured your glucose level throughout the test. So those are the criteria. Clients with diabetes are going to be prone to both hypoglycemia and hyperglycemia. So hypoglycemia is easily remembered by the mnemonic be tired. So these are the signs and symptoms you're going to see in your client. B stands for blurred vision. So when the blood sugar goes low, patients might complain of blurred vision. T is for tachycardia and palpitations. So when your blood sugar goes low, the sympathetic nervous system is activated. So that's why the patient's going to have tachycardia and palpitations. So that means they could have an irregular heartbeat. They're going to be tired and weak. I stands for irritability. If you know, like yourself, if you get hungry, you can get very hangry, right? And they could develop seizures. R is for restlessness and shakiness, which can also happen with hypoglycemia. E is for excessive hunger, like that polyphagia we've talked about. And D is for diuresis, again, because the sympathetic nervous system is activated when your blood sugar goes low. And there's a phrase, cold and clammy, give me candy, okay, because you're going to have to give some sugar to somebody that's hypoglycemic, and we're going to go into more detail about that. Now, hyperglycemia can occur in diabetics if they become sick. If they have some illness, that's often an early sign as having a blood sugar that is high, despite having good glycemic control previously to that infection. Okay, so in other words, they're still doing all the right things, but now they have hyperglycemia. This can also help it. These signs and symptoms would also be prevalent in clients who have not been diagnosed with diabetes yet. Okay, so you can remember it by the mnemonic AWIPS. So the signs and symptoms include A for acetone breath. Okay, that's that fruity smelling breath that you might see in somebody that's a diabetic. W is for weakness. Their wind is going to be heavy, meaning they could have Kussmaul's respirations. Recall, those are those fast, deep respirations because the body goes into acidosis. So the body tries to get rid of the CO2 by breathing hard and fast. H is for headaches. I is for increased thirst. So there's that polydipsia. And P is for polyuria, polydipsia, and polyphagia that happens with diabetes. And S is for sight is blurry. So in hyper and hyperglycemia, they could have blurry vision. And look for other common signs and symptoms. Okay. And the saying that we say when somebody is hyperglycemic is dry and hot, give me an insulin shot. Okay, as promised, the treatment for hypoglycemia is to give forms of glucose. If your patient is awake, you're going to give forms of glucose orally, and if they are unresponsive, you're going to need to turn them on their side and give 1 milligram of glucagon followed by another dose in 10 minutes if the first dose does not work. Okay? You may also be giving D50 IV if they are unresponsive. Okay, so you're going to give 15 to 20 grams of glucose if your patient can swallow. And I have different suggestions of the type of foods you can give. Remember that you never want to give diet soda. You want something with real sugar in it, okay? After you give some glucose, some form of glucose, you can recheck the glucose within 15 minutes. After you do that, then it's time to give longer acting glucose with protein. Like, for example, give them some cheese and crackers or give them a meat sandwich, okay? So you need something with protein to make the glucose last a little bit longer. Hyperglycemia is typically treated with regular insulin because it works quickly, like within 30 minutes. And when it comes to the IV form, only regular insulin can be administered IV. And that's going to become very important when we talk about the conditions such as DKA and HHS a little bit later on in this presentation. I talked about the long-term complications previously with the mnemonic knives, but it's really important that you know what teaching points or what you have to remind patients to do to maintain tight glycemic control so that they don't develop these long-term complications. Prevention is key. So to prevent a brain stroke or a cardiovascular disease, the patient has to maintain not only tight glycemic control, but blood pressure control. So they'll be on some kind of medication regime and they should stick to it and let their provider know if their blood pressure is not being maintained by the current treatment. Also, you will have to, as a nurse, teach patients how to take their blood pressure and record it daily. Patients should engage in smoking cessation because that helps also lower blood glucose levels. Um, you need to encourage them to continue taking their aspirin and lowering medications. Recall that patients with diabetes can have diabetic neuropathy. They can have silent MI, so they're going to need an EKG periodically to make sure that they haven't had a silent MI. Um, Cholesterol and hemoglobin A1Cs should be tested every 3 months. And how I remember that hemoglobin A1C is a test of compliance is the letter C in there. So in other words, it lets me know if my patient has been compliant with their diet for the last 3 months, right? Because they could cheat and just be compliant the last couple of days before they go to the physician's office, get their glucose drawn, and it could be great. But the hemoglobin A1C test for compliance, and it lets you know what kind of control they've had from their blood pressure over the last 3 to 4 months. Patients can develop diabetic nephropathy, so kidney problems, so they need an annual BUN and creatinine. Their urine also needs to be tested annually for microalbumin. Typically, the kidneys don't spill protein into the urine. However, if the kidneys do start spilling protein into the urine, you know there's some kind of damage with the vasculature in the kidney. And diabetes and hypertension are the two most common causes of chronic kidney disease. Okay, now patients to prevent diabetic retinopathy, tight glycemic control, definitely, and also tight blood pressure control, but they need an annual eye exam. To prevent periodontal disease, they need to have regular dental visits, to have teeth cleaning, and then with peripheral vascular disease and neuropathy, they need to check bath water because they don't have feelings, or they may have the feelings they may have in their lower extremities include like numbness and tingling. Okay, so those are some of the things that they can do to take very good care of themselves. Also, with the diet, no alcohol, no soda, those are good things. They probably shouldn't take acetaminophen or NSAIDs unless prescribed by a physician. Everybody needs to drink 2 to 3 liters per day to flush out the kidneys. And remember that the cornerstone of treatment is diet. And when it comes to diabetes type 2, diet and exercise, and maintaining tight glycemic control is key. Diabetic foot care is extremely important, and you as a nurse will have to teach clients with diabetes how to take very good care of their feet. They need to see a podiatrist at least once a year. They never want to soak their feet in hot water. Okay, inspect feet daily. That's very important. They need to check between their toes. Clean with soap and warm water. And then you want to make sure the skin is patted dry very well. Clean socks every day. I mean, you really need to tell patients about that. Cut the toenails straight across if it's allowed by the podiatrist. Keep the feet dry. They can't go barefoot because they can't feel if they stepped on something that they could have, a little abrasion or cut on their feet, and that just opens the skin up to bacteria. Okay, apply lotion to feet, but skip between the toes. No lotion or powder between the toes, and then they need to wear proper fitting shoes. So make sure they have um, heels, like they shouldn't wear slingbacks, etc. And then they need to bring an extra pair of shoes on vacation because if one set of shoes gets wet, they have another set to wear. And trim toenails straight across. I think I said that. Make sure that the room that they're sleeping in is set up and that they're not going to fall or trip over anything. Um, that's another thing they need to worry about with peripheral neuropathy if they can't feel their feet very well. There are exercise guidelines that diabetic patients need to follow, and you need to teach them these key points. So before exercising, they need to take their blood sugar. It needs to be between 80 and 250 because you don't want the blood sugar to go really low during exercise. They need to wear proper footwear for all those reasons I talked about in the previous slide with foot care. No exercise if ketones are present in the urine. So you're going to teach your patients if their blood sugar goes over 300, they also need to be checking for ketones in the urine more frequently. And I mentioned before, ketones are the breakdown of fatty acids in the body. So in other words, for some reason, the cells are not getting insulin, and so now the body is breaking down fat. You want to teach all patients to carry medical alert ID, but also they need to wear it when they're exercising. Check blood sugar more frequently in the 24 hours after an intense workout. Very important guidelines for exercise. As a nurse, you'll have to teach the diabetic client about illness guidelines. Like, for example, they need to notify the provider if their temp is greater than 101.5. They also need to notify the provider if they have ketones in their urine. If their blood sugar is greater than 200 and it doesn't resolve with treatment, they need to call their provider. And of course, if they start getting rapid breathing, because that could indicate they have Kussmaul's respirations, and if they can't hold down liquids, because typically if patients are ill and their blood sugar goes low, you're going to have them drink, those fast forms of glucose, such as soda. Now, you're going to encourage them. They need to take their blood sugar if they're ill every 2 to 4 hours. They need to continue taking their insulin and oral medications. When your body is under stress, it's going to be more prone to get a high glucose level. It's due to the sympathetic nervous system being activated, okay? So that's going to increase the glucose level in their bloods. You want to encourage patients to test their urine for ketones if their blood sugar goes greater than 300 and call the provider if they do have ketones. If you recall earlier, ketones are an indication that the body is breaking down fat because they are unable to use the glucose to nourish the cells, okay? And call the provider for ketones. All right, now we're going to talk about insulin. And I know you had this in pharmacology, but rapid acting insulin works in about 15 minutes, okay? You can remember the types by the mnemonic lag. Short acting, remember that's your regular insulin, and that takes about 30 minutes to 60 minutes to become activated. And then discard if it's cloudy, because regular insulin should be clear. And remember, when you are injecting air, it's cloudy to clear. And when you're drawing up, it's clear to cloudy. The intermediate form of insulin or intermediate acting is MPH insulin, and it is the only insulin that could be administered with regular insulin, and it is cloudy. So don't be tempted to shake it because you're not supposed to shake the vial before you draw up the insulin. Then the long-acting insulins, these are given once or twice daily, and the reason they're given is that they prevent peaks and troughs in a glucose level. So what that means, it's very important that you give it at the same time every day so there's a steady state blood sugar level. And then with the ultra long acting, these are 3 times more potent than than any other type of insulin, okay? Because we usually give U100 insulin. This is U300. So it does come in a pre-filled syringe if you need to give ultra long insulin, and that's to prevent medication errors. And so it has a duration longer than 24 hours. So metformin is an oral medication, oral hypoglycemic for type 2 diabetics. It works by decreasing the production of glucose by the liver. Therefore, you're going to look for signs of liver toxicity, such as jaundice or yellowing of the skin, okay? It increases their tissue sensitivity to glucose so that insulin can work inside the cell. Monitor for GI issues like vomiting, anorexia, and nausea, and flatulence. Diarrhea is another GI side effect of metformin. You need to hold it for 24 to 48 hours, 48 hours being preferable, before and 48 hours after tests with contrast dye to prevent kidney damage or kidney failure and lactic acidosis. Okay, so that's very important. Those are important interventions. Okay, there are 2 conditions that are life-threatening that can happen in diabetics, and depending if you have diabetes 1 or diabetes 2. So let's start with diabetic ketoacidosis, which occurs in type 1 diabetics. The onset is going to be very fast. So usually the patient may have like an infection of some sort, and this comes on really fast. Blood glucose is going to be 300 to 800 milligrams per deciliter. Usually it's less than what we would see in HHS, okay? Osmolarity is going to be high. And then with hyperglycemic hyperosmolar state, it's going to be very high, higher than usually DKA. The findings of diabetic ketoacidosis include the acetone breath, okay, and Kussmaul's breathing, ketones. So again, the body is breaking down fatty acids to nourish itself. They could have shock. So that means they could have tachycardia, tachypnea, and then finally their blood pressure will be low. They'll have extreme hunger, polyphagia, and thirst, polydipsia. They are going to be extremely dehydrated, so look for those signs of dry mucous membrane, skin tinting if they're young. Remember, older adults, that's not a valid sign to use. Altered mental status, weight loss, dry flushed skin, and headache. That's what you're going to see in somebody with DKI. It's treated with IV insulin and IV fluids, and the ABGs are going to show metabolic acidosis. Now with HHS, this happens in type 2 diabetics. The onset is going to be gradual. The blood sugar is going to be higher. It's going to start like greater than 600. Osmolarity is going to be extremely high. The normal osmolarity is 285 to 295. So in DKA, it's high, but in HHS, it's extremely high, like greater than 320. They're going to, with HHS, they will have an altered mental status. So you need to watch out for confusion, disorientation. They're going to have major dehydration. So all those signs and symptoms you learned last semester about dehydration, like the fast, thready pulse, okay? Dry mucous membranes, flat veins. So remember all those signs and symptoms. And this is going to be treated with IV fluids, IV insulin, and typically the pH is greater than 7.3. In other words, typically they don't get acidotic. All right, here's what treatment with DKA comprises of. You can remember the mnemonic ucking DKA. So fluids is going to be your first line. You're going to be giving them a lot of fluids because they're dehydrated. You also give a lot of fluids to people with HHS. Urea, you want to monitor the BUN. You want to monitor the creatinine as well. For potassium, or usually in the beginning of DKA, they're going to have a high potassium because of the metabolic acidosis. So you need to check and replace it. As you give insulin and sugar, the potassium will move inside the cell. So you need to check it and make sure they have a urine output before you give any potassium. They may need an NG tube. Glucose, you're going to give once levels drop to 250. Once the blood pressure gets to 250, you're going to switch your fluids from normal saline or 0.045, I'll go into more detail in a minute, saline to give fluid with D5 in it. Diet, once they can start eating, hopefully you can encourage them to eat. Keep track of the bicarb if we needed to correct acidosis. Anion gap, you're not going to need to really know about an anion gap for your NCLEX, okay? But the other interventions are very important. In general, patients with either DKA or HHS, this is a medical emergency, right? So vital signs Q 15 minutes until they're stable, then Q 4 hours. Monitor for dehydration, so go back and look at your MedSurg 1 notes about dehydration, or look up dehydration in your MedSurg book, the signs and symptoms. Older adults, you want to monitor for pulmonary edema, especially as you start adding more fluid, okay? So the crackles, S3 heart sound, JVD, all those signs and symptoms of pulmonary edema. Patients are going to need rapid infusion of normal saline, then they're going to switch to 0.45 normal saline, and they're going to need IV regular insulin to get the blood sugar down. You want to monitor the potassium. Early on, the potassium is probably going to be high in both conditions for different reasons. Check the urine output before administering potassium. Look for signs and symptoms of high potassium, and then once that is corrected, low potassium. Okay, write down your questions and bring them to class so we can go over them at the beginning of class.